Thank you for the opportunity to present a talk on STOPS agents, which are investigational agents for the treatment of chronic hepatitis B. My name is Matthew McClure. I'm the Chief Medical Officer of Alligos Therapeutics. These are the disclosures for Alligos Therapeutics. To begin my talk, what I'd like to talk about is a background on chronic hepatitis B and the achievement of functional cure. Chronic hepatitis B is a chronic infection primarily for two reasons. Number one, there's robust viral replication as manifest by high HBV DNA and RNA levels. Number two, there is suppression of HBV-specific immune response as measured by high surface antigen levels. In order to achieve functional cure, we need to stop both of these activities. Namely, we need to eliminate viral replication as measured by undetectable HBV DNA and RNA, and we also need to eliminate the suppression of HBV-specific immune responses by generating undetectable surface antigen levels. We believe this can be achieved by the use of therapeutics. In the case of viral replication, direct-acting antivirals such as nucleoside analogs and capsid assembly modulators such as CAMs are effective in lowering DNA and RNA levels. For lowering surface antigen levels, oligonucleotides, which target S antigen such as STOPs, ASOs, and siRNAs, appear likely to be able to achieve these undetectable levels of surface antigen. With that in mind, this explains the Alligos approach to the development of CHB drugs in the hopes of achieving functional cure. Essentially, our programs are designed to evaluate first monotherapy in an umbrella protocol. Initially, a phase 1A study in healthy volunteers where we evaluate safety and pharmacokinetics, followed by a seamless transition into phase 1B in the same protocol where we evaluate not only the safety and pharmacokinetics, but also pharmacodynamics in a patient population. Here, the drug is given as monotherapy, and the goal is to establish a dose range finding estimate of the drug which has the optimal risk-benefit profile as monotherapy, so that it can then be combined in a phase 2 study where we can assess functional cures. Those regimens that achieve higher than the standard of care in terms of functional cure rates in phase 2 may then be graduated to phase 3 and to pivotal phase 3 studies. Once you have the strategy in mind, we can now look at specifically S antigen transport inhibiting oligonucleotide polymers, or STOPs for short. These are novel, chemically optimized poly-AC oligonucleotide analog drugs. Important to keep in mind is the fact that poly-AC oligonucleotide drugs have clinical validation. The most obvious example is the Replicor 401 study. This was a study that evaluated Rep2139 or Rep2165, which are commonly called nucleic acid polymers, or NAPs. These are poly-AC oligonucleotides in which 250 milligram weekly IV infusions were evaluated in a triple combination regimen with nucleoside analogs and pegylated interferon. In this study, you can see in the figure to the right, there were dramatic reductions in surface antigen levels, and perhaps more impressively, there were very high rates of functional cure, approximately 39%, which is much higher than the functional cure rates that are observed with standard of care, which is less than 5%. So in short, these NAP molecules in combination with nucleoside analog and pegylated interferon were able to achieve multiple log reductions in surface antigen and substantially higher rates of functional cure versus the standard of care drugs. Now, it's important to keep in mind, though, that the Rep 401 study was triple therapy. What happens when NAPs are given as monotherapy? We know this from the Rep 102 study, where Rep 2139 was administered for greater than or equal to 20 weeks in a patient population of CHB subjects. We have taken the figure from that abstract or in publication, and we've shown the data through 10 weeks to show you that even over a very short interval of 10 weeks, you can see dramatic reductions in surface antigen levels. The mean reduction is about 1.7 logs, but this is because it's a mixture of non-responders and super responders. And indeed, you can see that in the standard deviation, which is 2 logs. So in summarize, even as monotherapy with the NAP molecules, you can achieve dramatic reductions in surface antigen levels over even a 10-week interval, although it is associated with marked heterogeneity. So with these clinically validated information for NAP molecules, we embarked upon an extensive structure-activity relationship effort using our proprietary chemistry to see if we could identify novel poly-AC oligonucleotides. And ultimately, we were successful, and we call these molecules STOPS molecules. You can see our lead molecule, ALG 010133, in the blue curves on the left and right figure, and the reference NAP molecule in the red curve on the left and the right part of the figure. And what you see here is an approximately 100-fold improvement in potency versus NAPS molecules. And this, in theory, should enable subcutaneous administration as well as widening the therapeutic index due to this enhanced potency. Now, how do STOPs work? This is a complex question that is still being elucidated. However, STOPs appear to interact with host proteins, and specifically 5 proteins which are known to be necessary for optimal surface antigen production. And these are proteins that have previously been shown to have a role in other viral infections such as HIV and CMV. Now, this mechanism of action is complex and still being elucidated, but we can say in broad brushstrokes that the sequestration of proteins leads to the degradation of intracellular surface antigen, as well as a decrease in the production of surface antigen. So in summary, STOPs appear to decrease surface antigen production and increase surface antigen degradation via interactions with host proteins. Now, equally importantly is not only do STOPs appear to lower surface antigen levels in vitro, but they also appear to act synergistically with other CHB mechanisms of action. Specifically, we've combined the STOPs molecules with antisense oligonucleotides and shown synergistic reductions in surface antigen levels. We've also combined our STOPs molecule with capsid assembly modulators and demonstrated synergistic reduction in DNA activity levels. So with that information in hand, we embarked upon a phase 1A, 1B study to evaluate STOPs molecules at first in healthy volunteers, then in patients. We followed a typical single ascending dose followed by multiple ascending dose study in healthy volunteers, where you have 8 subjects per cohort, 6 active, 2 placebo. In the SAD, we evaluated single subcutaneous doses between 20 and 200 milligrams. And in the multiple ascending dose study, we evaluated 3 weekly subcutaneous doses of 120 or 180 milligrams. The healthy volunteer portion of the study is complete. And as you can see in this figure, the pharmacokinetics appear to be predictable and well behaved. We were able to achieve dose linearity at doses greater than or equal to 125 milligrams, and there was no evidence of accumulation. From a safety perspective, there were no serious adverse events, and there were no treatment emergent adverse events leading to study drug discontinuation. We did commonly see injection site reactions in about 19% of STOPs treated subjects, but this is a similar ISR rate to other oligonucleotides, such as ASOs and siRNAs. There were no clinically concerning ECG, vital sign, or physical examination findings. So in summary, in healthy volunteers, single and multiple 133 doses were generally well tolerated, and prophylactic topical steroids are being used in the CHB portion of the study in order to mitigate injection site reactions. We are currently engaged in enrolling subjects with chronic hepatitis B and evaluating STOPs molecules. The patient population is NUC-suppressed subjects who are E negative and have at least 2 logs of surface antigen at baseline. It's a typical MAD study design, so there's 10 subjects per cohort, and they're getting 8 are getting active and 2 are getting placebo. And subjects are dosed with up to 12 weekly subcutaneous doses, with the endpoints being, of course, pharmacokinetics and safety, as well as importantly, surface antigen levels. Dosing in the first 2 cohorts at the 120 milligram and 200 milligram dose levels are fully enrolled. And the 3rd cohort, which is enrolling at 400 milligrams, is currently enrolling. This is, of course, a dose range finding study. We're trying to identify a dose level that has an optimal risk-benefit profile, and we're targeting a mean surface antigen reduction of at least 1 log, which is similar to the 102 data, the Rep 102 data, which I showed you earlier at week 10. We expect to have data for the first 3 cohorts in the STOPs phase 1B portion of the study in the first half of next year. So in summary, poly-AC oligonucleotides such as NAPs have reported unprecedented functional cure rates, approximately 39% in chronic hepatitis B. However, there are important limitations of NAPs. For example, IV administration is required. By contrast, STOPS agents, which have been identified by Alligos, have a 100-fold enhanced in vitro potency versus NAPs, which enables subcutaneous delivery and may widen the therapeutic index. STOPs appear to have a complex mechanism of action, which is still being elucidated, but it appears they interact with multiple host proteins, resulting in decreased surface antigen production and increased surface antigen degradation. STOPs appear to act synergistically with other CHB mechanisms of action, such as antisense oligonucleotides and capsid assembly modulators. On the basis of these data, we've embarked upon a phase 1AB proof of concept study of our STOPs molecule, which is currently ongoing. The drug was generally well tolerated in healthy volunteers, and we're currently evaluating 12 weekly subcutaneous doses in E-negative CHB subjects. We expect to generate top-line data in the first half of next year with a target mean surface antigen reduction of at least 1 log. As a reminder, this is a dose range finding study. It's designed to identify the dose with the optimal risk-benefit profile, which will then be advanced into phase 2 curative combination studies. Thank you for the chance to present our STOPs molecule.